Welcome to Alzheimer's Universe. This lesson is meant to be a primer for our ALZU course for healthcare providers entitled The Clinical Practice of Alzheimer's Prevention, a Precision Medicine Approach. We will now cover the history of the Alzheimer's Prevention Clinic at Weill Cornell Medicine and New York Presbyterian, and provide a brief introduction on how to care for an Alzheimer's prevention patient. The rest of this course will cover topics such as who is an Alzheimer's prevention patient, how to assess an AD prevention patient, and how to create personalized Alzheimer's prevention plans using baseline and longitudinal assessments. Throughout this course, we aim to give healthcare providers of different backgrounds an overview of how to take care of patients to reduce their risk of Alzheimer's in an evidence-based and structured way in line with their individual expertise and resources. We will now provide an overview of how the Aapc was started and how it works day to day, which can help serve as a real-world framework for those that may want to start a practice themselves in the United States or globally. By the end of this lesson, we hope that you will see that the clinical practice of Alzheimer's prevention is feasible, and reducing Alzheimer's risk may be possible through evidence-based, personally tailored interventions. The Alzheimer's Prevention Clinic at Weill Cornell Medicine and New York Presbyterian has been providing direct clinical care to patients with a family history of Alzheimer's disease since 2013. Patients seeking to lower their risk undergo a comprehensive assessment and receive evidence-based, individualized, early intervention plans applying principles of pharmacogenomics, nutrigenomics, and clinical precision medicine. According to the National Institutes of Health, precision medicine is defined as an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. A common methodological constraint of randomized controlled trials, even those that have demonstrated positive outcomes, is their experimental focus on quite homogeneous study cohorts that make it difficult to generalize results to the unique patient sitting in front of a clinician. Most commonly in medical practice, treatment plans are designed for the average patient based on the best available evidence, incorporating a broad spectrum of data from heterogeneous cohorts that may or may not be directly applicable. It may be most practical to provide patients with an individualized, detailed plan, fortified with qualifiers, for reducing the risk of dementia after an extensive evaluation of their medical history, lifestyle factors, body composition, laboratory, and cognitive assessments. A comprehensive, multimodal management plan can then be carefully crafted by cross-referencing each data point, and the patient is then followed longitudinally to evaluate the effectiveness of this clinical precision medicine intervention. As an Alzheimer's specialist who has several family members with this disease, my clinical practice and research has focused on providing the latest evidence-based and comprehensive management options for treatment as well as to reduce risk. Most people are unaware that Alzheimer's disease begins in the brain over 20 to 30 years before the first symptom of memory loss. This leaves ample time for people to make brain-healthy lifestyle and dietary choices for this preclinical or pre-symptomatic stage in an effort to delay onset. Initially, the clinic was staffed by one neurologist with the help of a clinical secretary to help manage appointments and the usual office calls. During the first year, visits at the Alzheimer's Prevention Clinic included a 1.5-hour introductory visit with the clinician. The visit began by discussing clinical and family history and was followed by biometric analysis, at the time using a very inexpensive body fat sensing scale, and also ordering of routinely available tests and labs to detect modifiable risk factors. In addition, some limited online cognitive testing via Alzheimer's Universe, www.alzu.org, was completed. This website is a free online resource created to educate clinic patients and the public at large about Alzheimer's prevention and treatment. The site also includes tools to help assess and track cognitive function over time. As the evidence expanded, we added additional metabolic, lipid, inflammatory, and nutritional risk factors for cognitive decline to our lab panel that we followed over time. In January of 2014, the basic lab panel was replaced with a more comprehensive and advanced panel that has been more commonly used in the preventative health and preventative cardiology fields as part of routine clinical care. These included a lipid panel with advanced measures such as LDL particle size, common diabetes screening tests such as hemoglobin A1C, fasting insulin, and adiponectin, nutritional markers such as serum omega-3 levels and omega-6 levels, as well as their ratio, as well as a host of other markers such as cystatin C, which is one of the more recent blood biomarkers of AD risk. We also included genetics for the first time, including the ApoE and MTHFR genes to help better personalize care. For each modifiable risk factor that was treated, each patient would receive typed-out recommendations on how to address individual risk. Additionally, since the treating physician was intervening and spending considerable counseling time to educate the patient, the clinic practitioner would be able to bill for this time using the code corresponding to the modifiable risk factor being treated. In July 2014, a second neurologist with fellowship training in cognitive and behavioral neurology and epidemiology was recruited to be able to accommodate the long waiting list of patients and to help further develop the clinical research program and patient registry. At this time, we also added more comprehensive cognitive testing performed at each visit in the clinic. This was essential in an effort to both obtain a baseline, but also to track cognition over time and evaluate response to therapies. A half-time research coordinator was hired to administer cognitive testing, which was facilitated using the NIH toolbox via the computer, as well as several more traditional pen and paper tests. Each session initially lasted about an hour, with later expansion of the battery to an hour and a half. While the cognitive testing was able to be interpreted by and billed for by the treating neurologist, we then needed some additional help from a research perspective to help analyze the data being collected. We added 2 part-time remote neuropsychologist consultants, Dr. Robert Krikorian from the University of Cincinnati, who has a specialty and research interest in nutrition in the brain, and Dr. Josefina Melendez-Cabrero, a clinical neuropsychologist who is currently now the director of the Alzheimer's Prevention Clinic and Research Center in San Juan, Puerto Rico. This was essential to help assist with our further development of the neuropsychological battery as well. Thanks to philanthropic support, additional consultants were brought on board on a part-time basis, including a preventative cardiologist, social worker, registered dietitian, and a variety of other multidisciplinary specialists. We also hired several research coordinators, currently Catherine Hackett, who will be pursuing graduate school for neuropsychology, and Emily Caesar, who will be pursuing medical school in the future. Again, due to a growing waiting list and interest from throughout the country, a business plan was developed and we hired a nurse practitioner in 2016. Most recently, an associate director of the Alzheimer's Prevention Clinic, Dr. Lisa Mosconi, was recruited to oversee and help grow the research program. While we gradually recruited more and more team members to support the clinic's expansion in terms of patient care and clinical research, it is important to remember that it is entirely feasible to start and remain small. In fact, we have collaborated with several other healthcare providers who have had success in caring for Alzheimer's prevention patients using a very much adapted framework, and in collaboration with our core team members with broad expertise, able to provide as state-of-the-art care as possible.
Hi, my name is Holly Herstoff, and I'm a nurse practitioner in the clinic, and I'd like to give you a brief overview of how patients begin their APC journey. The first step is the easiest and can be done in the comfort of their own home. A baseline pre-visit questionnaire is emailed out to the patient several weeks prior to the visit with the physician. This survey takes the patient approximately 30 to 45 minutes to complete and assists our team during the initial visit, as well as in monitoring the effectiveness of our care over time. If you are interested in receiving a copy of this for adaptation, please reach out to us via alzu@med.cornell.edu. After the baseline survey is completed, the patient is prompted to visit alzu.org, where they complete the first 2 lessons on Alzheimer's risk factors and disease. The patient also completes 3 activities, including a 5-minute cognitive eye tracking assessment called NeuroTrack, the 15-minute cognitive function test, and the 5-minute face name test. Once these tasks are completed, the patient is ready for their APC visit. It has been essential for the efficiency of our program to only accept a patient to be seen when these steps are complete and to not make exceptions. The approach to clinical care at the Aapc is to provide written, multimodal precision medicine interventions that are generated towards risk reduction. Among many others, we focus on nutrition, physical activity, stress reduction, social interaction, sleep hygiene, musical interventions, specific cognitive activities, and regular follow-up with a primary care doctor. Each suggestion is tailored specifically for each patient, as there is a no one-size-fits-all approach. A few vitamins or supplements may be suggested, and referral to other subspecialists may also be helpful, such as a preventative cardiologist for cholesterol management or further cardiac risk stratification. In other lessons in this course, we will cover a more detailed guide on how to provide care using clinical precision medicine for Alzheimer's prevention. All care provided is evidence-based and generally very safe. There is no one algorithm to Alzheimer's prevention, nor should there be. A personalized or tailored approach is mapped out for each individual patient. With the guidance of the Aapc, the patient is able to feel they are more in control of their destiny, and we have found that education is the key driver when it comes to overcoming fear.
The information provided thus far should serve as an initial overview, but if you're interested in taking steps to also care for Alzheimer's prevention patients, feel free to reach out to us. It is also important to note that while research is highly important to us, the Aapc is primarily a clinic, and our priority is to gather all relevant information for each patient so we can better assess risk and intervene accordingly. Research is secondary, yet has been an extraordinarily informative experience thus far. Additional lessons in this course cover several of our research findings as well.